Thank you so much, Dr. Bartels, for the introduction and for the opportunity. It's great to be with you all today, and looking forward to sharing some of our work related to implementation strategies. And as I mentioned to Dr. Bartels, feel free to interrupt early and often. It's okay if I don't get through all the slides, but hopefully we'll have time at the end for questions as well. But certainly don't be shy. Just by way of overview, I hope to cover a few sort of main topics today. The first is I'd like to spend some time talking about some of our work to think about how we can better identify and classify implementation strategies. And then I'll spend the bulk of the time discussing, some advancements with respect to designing and tailoring implementation strategies and some of the emerging directions with respect to evaluating implementation strategies in the field. And apologies if this is way too basic probably for this group, but just to level set here, we've defined implementation strategies as methods or techniques used to enhance the adoption, implementation, sustainment, and scale up of a program or practice. And admittedly, the implementation strategies that are likely of interest to you vary quite substantially in terms of their complexity. So sometimes we talk about discrete implementation strategies, which involve a single action or process. So we can think about things like clinical reminders, audit and feedback, or clinical supervision, for example, as discrete implementation strategies. But more often than not, right, we're dealing with complex interventions that involve multiple discrete implementation strategies, hopefully that are combined in sensible ways. And so you might see the term multifaceted strategy or implementation intervention in the literature, or other terms to describe which essentially is a combination of discrete strategies. Again, perhaps too simple, but like to provide this just as an example of thinking through, ideally we would be, identifying barriers and facilitators to implementation, and based upon the types of changes that we'd like to see and the types of barriers that get in the way, we'd be selecting strategies to address them. So for instance, if there's a lack of knowledge, it might be that sort of an interactive education session is a sensible implementation strategy to use. If there's a perception reality mismatch, so for instance, if you have a group of clinicians that say, we're already delivering evidence-based practice, we're delivering to this sort of guideline concordant care in this way, it might be that administering a fidelity measure or some sort of quality measure and feeding that back to clinicians in comparison to their peers might be a sensible implementation strategy, and so on and so forth. And when we move into the sort of the multi-level context, or we have multifaceted, multi-level implementation strategies, we hope that they're designed in a way that is synergistic, right? Such that 2 + 2 is 5, even more than 4. And so this is an example taken based on a nice paper that Brian Weiner and his colleagues wrote in 2012 in the Journal of the NCI, I believe. This is work by Sam Schilling, who is a childcare pediatrician and was really working to promote the use of a primary care-based child maltreatment prevention intervention. And what you see here are the different implementation strategies in the rectangular boxes. Hopefully, first of all, working in a synergistic way overall. You see something like public recognition and parent narratives being used in an accumulative fashion to address clinician motivation. We have an audit and feedback intervention that's meant to actually amplify the effect of those two implementation strategies on clinician motivation. And then hopefully preparing parents to be active participants improves parent motivation, and that clinician motivation and parent motivation, work synergistically to improve the parent-clinician interaction. And then finally, the fourth sort of pathway here is a clinician reminder that's meant to facilitate the effect on these implementation strategies, ultimately on the outcome of interest here, which is referral to primary care. And this is just one way of thinking about how we might put together multiple discrete strategies. And the paper that Sam led here, I think also does a really nice job of providing theory and evidence for these discrete components and describing how they might work together. Some of the work that we've done has been to actually just name and define implementation strategies. Originally going to the literature to ask, what are evidence-based implementation strategies, and finding what we often see referred to as this Tower of Babel problem, in that people are talking about strategies in all different kinds of ways, using inconsistent terms. And so in 2012, we published this compilation of implementation strategies based on a review of the health and mental health literatures. And then we had an opportunity to build off of that literature review using a modified Delphi process and a concept mapping exercise that basically allowed us to engage implementation, research, and practice experts in vetting this list of implementation strategies and definitions. And these publications are shown here on the right. Ultimately, this yielded a compilation of 73 discrete implementation strategies. I didn't have it here on the slide, but sometimes in implementation science, the good stuff is hidden in the additional files of these articles. So the 2015 article here has an additional file 6 that has probably the more comprehensive version of this compilation, if you'd like to take a look. But these were categorized into these 9 broad categories of implementation strategies. I'm not going to spend a lot of time on this today, but happy to talk about that more in the discussion if helpful. The idea here is that these strategies can serve as these discrete strategies can serve as building blocks of multi-level, multifaceted strategies for research and practice. And hopefully they do some small part, at least, in promoting a common language and improving reporting in the field. Although, as you'll see in subsequent slides, this is sort of an evolving process. Things are continually being refined, and there's nothing magic about this list of strategies, right? So if you're thinking about implementation strategies, you should in no way feel constrained to this list or other compilations or taxonomies that are currently existing in the literature. So people are continually, I think, building upon this work. One example of some work to apply what we call the expert recommendations for implementing change compilation, that taxonomy of implementation strategies, has been through the work of Sherry Rogal and Vera Yakovchenko at the University of Pittsburgh. And they've turned this compilation actually into a survey. So they've used this retrospectively to assess national implementation efforts within the Department of Veterans Affairs. And so don't mean to overwhelm with the screenshots here, but just wanted to share some of her work to do that. So some of the empirical findings from that survey work are on this top row of articles here. They've also used something called configurational comparative methods, which I wanted to point out. This is sort of if this group hasn't talked much about this, this is a method that allows us to sort of think about which combinations of implementation strategies are both necessary and sufficient to achieving your outcomes of interest. And so it's an interesting method for implementation science in particular, in dealing with this issue of equifinality, that there's more than one way to be successful in implementation. And so thinking about the different pathways to success, I think those bottom articles are a nice example of that. And as I point out on the slide, there's work ongoing to refine this survey based upon multiple applications from Sherry and her group. We've also seen extensions of this ERIC compilation in multiple areas. So in school mental health, digital mental health, and an extended compilation of financing strategies in behavioral health. I should have noted the piece of my focus in social work and mental health, so forgive me if too many examples are in that area. But there have also been questions about sort of how does this compilation fit with different areas. And so recently, colleagues led by Nicole Nathan have really asked the question of how do implementation strategies and as defined in this ERIC compilation apply to sustainment efforts. And so mapping this onto a framework of sustainment determinants and seeing what sort of additional strategies are necessary and language tweaks are necessary to apply it to sustainment. That's represented here on this publication on your left. And then we also used Sarah Ingvarsson and colleagues from Karolinska have used this compilation to code de-implementation strategies. So, I'm sure this group talks about de-implementation. How do we get people to stop doing things that are, no longer effective or potentially harmful? And so in this implementation science article on the right, the compilation was used to code those interventions and found that there's a lot of overlap between implementation strategies and de-implementation strategies. At least we could make a fit for most of them. Another question that we often get is sort of how are these strategies how are they relevant and how are they being applied in international contexts, low and middle income countries, other contexts beyond the US? And that's a great question because the compilation was developed in a very sort of North America centric fashion. We had most of our experts from the US and Canada. And I'm really pleased to see colleagues extending the compilation and sort of thinking about implementation strategies more broadly. The link on your left is from a living meta-analysis of implementation science studies in low and middle income countries led by Dr. Elvin Gang here at WashU, who is an infectious disease physician and has led this really interesting study where they've coded, as you can see here, 623 implementation studies, where they've coded the implementation strategies in great detail to describe, who are the actors involved, what are the action targets that they're after, and really trying to use things like the ERIC compilation, but also behavior change techniques from Susan Mickey and colleagues and other reporting guidelines and implementation science to really describe these strategies in detail. So I'd urge you to take a look at the dashboard that's represented in the link below. And also pleased that Kate Lavero, who's a colleague at Columbia University, has also recently completed a scoping review of the use of this taxonomy in low and middle income countries. And so we're learning interesting things about how these strategies are applied and which ones might be the most relevant. And I think this is my last taxonomy talk, so forgive me if this has been a bore, but the strategies as described in the ERIC compilation have also been, I think, usefully combined by Sheena McHugh and colleagues in this paper in the middle to flesh out sort of the core ingredients of some of these strategies. So if you're familiar with the behavior change technique taxonomy, this is a taxonomy that was developed by Susan Mickey and colleagues at University College London in the UK. And so primarily health psychologists that have really tried to identify the active ingredients of interventions and implementation strategies. Many of those are described at a sort of a more granular level than the implementation strategies as we discuss them. So we think it's one way of thinking about sort of what are the core functions of some of these implementation strategies. And in some ways, some of the implementation strategies as described in the ERIC compilation actually provide more detail or sort of meat on the bones than some of the behavior change taxonomy strategies do. So feel free to check out the middle paper if you want to see some of that. It's really sort of more proof of concept, but we think that these taxonomies can be used in a complementary fashion to help us better describe interventions and implementation strategies. Not meant to take in all of this slide, but just to say that there's a growing evidence base for implementation strategies. And I often point people to the references and links at the bottom of this slide. So the Cochrane Effective Practice and Organization of Care group, if you're not familiar with it, has a number of systematic reviews and meta-analyses on implementation strategies. There's also a really nice website run out of McMaster called healthsystemsevidence.org, which allows you to search for specific types of implementation strategies. And they provide graded systematic reviews and meta-analyses that are really doing a nice job of synthesizing the evidence for implementation strategies. And so it's great to see a growing body of evidence there. And the other thing that I wanted to highlight quickly with respect to that is, as I'll talk in a little bit more detail towards the end of this talk, there's increasing emphasis in implementation science of focusing not just on whether or not strategies work, but how and why they work. So sometimes if you read Cochrane reviews and things like that, they don't necessarily provide you super helpful guidance from sort of a practice policy perspective of what types of strategies to use, or even, you know, how you should deploy them. And so this is maybe just, you know, one example of pushing beyond that. This is from a realist review of pay for performance in low and middle income countries by Singh and colleagues, published in Social Science and Medicine. And what they do is really walk through a nice process of, first of all, describing an initial program theory for pay for performance in these settings, then conducting a literature review, which includes mixed methods evidence. So drawing upon not just, you know, RCTs, but also qualitative and mixed method studies to describe how and why this strategy works or fails. They then revised their program theory, and as you can see, also represented this using sort of a system science-based method and causal loop diagrams. This looks, you know, very complicated in this diagram and probably not easy to see, but if you look at their article, they break down various sections of this that I think really do a nice job of describing how and why this implementation strategy works, which hopefully is more informative to practice and policy. So one of the next sort of emerging or I think priority areas for implementation science is really developing methods for designing and tailoring implementation strategies. So, you know, we have an emerging or we have a sort of established list of implementation strategies. We have evidence base for some of them. But how do we inform decision makers, whether it's you know, organizational leaders, system leaders, policy leaders, in terms of which implementation strategies to select? And Michelle Vensing and Richard Grohl have noted that, unfortunately, despite, you know, the desire to have strategies that are really well matched to context or specific determinants, there's often little association between the types of implementation strategies we actually use and the problems that they're intended to address. There's also, as they note, a phenomenon that we see: organizational and system related problems tending to be ignored even when they're detected. So a lot of our strategies are sort of at the provider or individual behavior level, and with less of a focus on organizations and systems. And so we think that there are a lot of opportunities to improve the deployment of implementation strategies, and have listed some priorities here. One of which is the emphasis of this section, which is enhancing the methods for actually designing and tailoring implementation strategies. I'm also going to talk today about specifying and testing mechanisms of change and improving the tracking and reporting of implementation strategies, so that our efforts are more replicable and we can learn from the work that we're doing. This is sort of a relatively generic set of steps for designing theory-informed implementation strategies. And I think, you know, for those of you who are intervention developers, this is going to look familiar. This is also quite consistent with intervention mapping or implementation mapping, if you're familiar with those approaches. And the first step is really just to identify who needs to do what differently in order for implementation to be improved. So what types of behavior are we trying to change? Who needs to be engaged in that process? The next step is really using informal and formal theory and frameworks, which I'm sure this group has talked a lot about, to identify barriers and enablers that need to be resolved, and hopefully to articulate a pathway of change for targeting, for the targeted behavior to occur. And I'll just note here that, you know, we can, you know, bring a lot of different research methods to bear here, including, you know, literature reviews. And I think increasingly, as we develop a body of evidence for the types of implementation barriers and facilitators in various settings, it's often obviously wise to start with literature reviews. It can also involve qualitative and quantitative data collection, and sort of more or less formal methods for identifying barriers and facilitators. The next step is hopefully then to develop or select implementation strategies including, the behavior change techniques and modes of delivery that might be effective, relevant, acceptable, and feasible to overcome those challenges. And then to decide how implementation can be feasibly and robustly measured. And I just note here, not to sort of pay short shrift to this in this presentation, but obviously important to consider equity during each of these steps, and point out a paper here from Larissa Gaius that I think is a nice process model for considering equity in developing or adapting implementation strategies, and the types of considerations you might have at each of these steps. So we have some evidence that actually designing and tailoring implementation strategies in systematic ways, and tailoring them to specific contexts is effective. So this Cochrane review shows that the tailored approaches are often superior to standard approaches to implementation. But they also note, like many of these reviews, that it's not yet clear how best to tailor implementation strategies, and therefore not clear what the effective and optimally tailored intervention would be. This is a review that's currently being updated, and so we're sort of in the thick of that. This is led by Sheena McHugh at University College Cork in Ireland, and so we're excited to find out, hopefully, how this evidence has evolved in the last several years, but also how methods for actually tailoring implementation strategies have evolved, because I think there's a lot of room for creativity here. And in the course of that work, we've been thinking about a lot of sort of conceptual and methodological tensions with respect to tailoring. First of all, what do we even mean when we say tailoring implementation strategies? So just to give a quick example, some people just mean designing, implementation strategies with a consideration of barriers to facilitators. So sort of like just, carefully designing an implementation strategy. Others mean, adapting or tailoring the approach to specific sites. So the definition differs. The questions about what level is appropriate for tailoring, should things be, tailored at a broad geographic level? Should they be tailored at the site level, the clinic level, the team level, and so on and so forth? How do we consider the stages and timing of this? And then what are the methods that we can even use, for instance, to match implementation determinants and implementation strategies? And again, I think a lot of room for innovation and creativity here. So I know many of you are probably already working in this space and developing and applying these methods. So great to see that in the field. Some examples of these methods are in these two papers, and so just to call out a few, in this paper on the left, we identified group model building, intervention mapping, conjoint analysis. You see the use of other discrete choice experiments and the like as methods to think about designing and selecting implementation strategies. In this systematic review by Heather Cahoon, she identifies 15 papers with replicable methods, and again finds a lack of focus on organizational level changes and system level changes. And so I think a lot of opportunity for growth. Just to give one concrete example of a study that I'm involved in with colleagues at University of North Carolina. In this case, we're actually using two of those methods identified on the earlier slide. This is from a NHLBI funded R01, where we're actually using concept mapping as a method of engaging a wide range of stakeholders and identifying barriers and facilitators, prioritizing them, and then using a system science method called group model building to actually think about the complex relationships between these barriers and the intervention points, and ultimately develop sort of an implementation plan or blueprint for moving forward. And so studies like this, I think, are nice opportunities to sort of use these methods in a systematic way and hopefully provide evidence that they can be useful from an implementation perspective. So I mentioned the ERIC compilation already. This is a paper led by Tom Waltz, where We linked the ERIC compilation implementation strategies to the determinants in the consolidated framework for implementation research, which I'm assuming this group is familiar with, a common determinant framework in the field. And the idea here is that if we identified a specific determinant that we would like to address, this is a tool that can point to at least some of the implementation strategies that you might consider in addressing that particular determinant. So hopefully the strategies are on this slide are intuitive enough in addressing a barrier like low, reflecting and evaluating in an implementation context. No money back guarantee on this tool, but hopefully it can be a starting point. One of the things I often say about this is that the actual operationalization of the strategy is really where the work is after identifying potentially relevant strategies. So that tool is really kind of at a broad level. And one way to think about how we might operationalize these strategies in more detail is through methods like intervention mapping or implementation mapping. And I think for the sake of time, I'm not going to dwell on this here. This is quite consistent with the process for developing theory-informed implementation strategies that I shared on a previous slide. But just to say, intervention mapping is an established method in public health. I've heard it described as sort of just what good intervention developers do. So it's not going to seem totally different than probably other things that you're familiar with. But increasingly, this is being applied in implementation science, and some of the steps and sort of the ways they're being operationalized. I think there again is room for innovation and tweaks to the model. So I usually say I'm doing at least some butchered form of implementation mapping in my work, and we're trying to make this a useful and pragmatic method for a variety of settings. So in one of these studies, we actually used implementation mapping to tailor implementation strategies at a clinic level. So using this with child and adolescent mental health service agencies to co-create implementation plans at their organization, and really walking through the steps of implementation mapping to do that. We've also done this within the context of implementation trials to conduct formative work to actually develop the implementation strategies. So sometimes when we submit these grants, we don't always have the implementation strategy perfectly spelled out yet, but we spell out how we'll use implementation mapping to develop an implementation strategy that will then be tested, for instance, using a cluster RCT in this case. And so in this case, we used implementation mapping to develop an approach to tailoring implementation strategies at the organizational level, and to develop a standard implementation condition. And just wanted to point out this special collection in Frontiers. If you want to see more sort of examples of intervention mapping or implementation mapping applied in this area. I think I'm going to skip this, but just a brief intro just to say this is a forthcoming paper. We have an annual review of public health that is getting at this idea of on-the-go adaptation or adaptation that happens throughout the course of implementation. We kind of know in practice that this is what happens, right? We try something, we see if it works, and we adapt on the go and hopefully make better decisions. And in this paper, I think in part, we argue that we need to be more systematic about how we do this and to think about how we consider the effects of adapted interventions and implementation strategies. And I think it also is consistent with movement in the field to look at things like adaptive implementation strategies that are developed through sequential multiple assignment randomized trials, or as our colleague Danny Amaral from the University of Michigan has really have been presenting lately, multi-level adaptive implementation strategies, or MAZES. If you haven't heard Danny talk about that, it's a treat, and he's actually presenting, I believe, next Tuesday, the 24th, through the Prevention Science Methodology Group, or PSMG, if you're familiar with that group. So I mentioned that there's an increasing focus on how and why implementation strategies work, and this is from the probably familiar program announcement from the NIH that calls for the identification of possible mediators, moderators, and mechanisms of action that explain the impact of dissemination and implementation strategies on relevant outcomes. And just quickly to sort of cover what we know about implementation mechanisms, and I think in short, the answer is not much. These are findings from 2 systematic reviews that suggest that our knowledge is pretty thin about how and why implementation strategies work. So there's been less attention to that than is probably warranted in the field. And why does that matter to us? And I'm sure there are more reasons than this, but just to suggest a few. One, to the sort of previous chunk of this presentation, failing to understand how and why implementation strategies work and to really theorize about that hinders our efforts to systematically design and tailor implementation strategies. 2, it limits our ability to learn from negative studies and to replicate positive findings. And I'll give one example of a negative study where having a better understanding of implementation mechanisms could be helpful. It also prevents the successful adaptation of an implementation strategy developed in one setting to another without sort of decomposing and thinking about what are the mechanisms through which this strategy works. We're not necessarily clear on how and why it might work in another context or setting, and so ultimately this limits our understanding of generalizability and the role of context in implementation. This is again too simplistic, but just wanted to provide some examples of how we might think of the mechanisms of implementation strategies, and so just to provide a couple of these. Again, if we have something like a provider skill deficit and we use a strategy like training or teaching in practice with corrective feedback, we might think about this operating through the mechanism of skill acquisition, refinement, and mastery, and ultimately influencing an implementation outcome like fidelity, right, to the actual evidence-based practice. And oftentimes we don't necessarily measure these mechanisms. So we might not measure skill acquisition, refinement, and mastery in our work. And there are several other examples here. But the idea is that we should be theorizing about this and specifying these ahead of time, and then again, adapting our understanding of this over time. In some of our work, this is a paper that came out of a failed R01 application that is, I think, on the 4th try successful, and we're in the midst of now. We talk about using causal pathway diagrams to depict this, and talk about mechanisms as the processes or events through which an implementation strategy operates to affect the desired implementation outcomes. So essentially, thinking about the implementation strategy, the mediators and moderators that may influence its success in relationship to these proximal and distal implementation outcomes. There's nothing sacrosanct about the way we represent this. We had our sort of methods and meta science group here at WashU this morning, and we were talking through DAGs and sort of how you use that to represent implementation strategies and mechanisms, and how that tool can be used. And so others may be using other ways of depicting this. Yet another way of showing mechanisms of implementation strategies here. And this is the example I was suggesting of a negative study. So what motivated this was a study with null findings of an implementation strategy called knowledge brokering. It was intended to influence evidence-based staffing in a hospital setting. And what we show here is that oftentimes we might do a trial, and this is sort of what we depict on the top. But as we think about the hypothesized mechanism of the implementation strategy, we can sharpen sort of our understanding of how and why this is supposed to work. So just for sort of one of these pathways, A knowledge broker might work to cultivate a social link. So there's some relationship development to provide brokered knowledge of the evidence. So packaging the evidence and simplifying it, contextualizing it for, in this case, hospital managers. Hopefully the manager then absorbs and understands and integrates that managed knowledge, makes changes and ultimately leads to evidence-based staffing. And specifying the mechanism in this way allows us to think about what contextual factors actually might matter. So for in this example, the status of the broker and the positioning of the broker within the organization matters. I think in this case, it may have been even postdocs that were used as the knowledge brokers, maybe didn't have the relational purchase that you might like to see for a knowledge broker. So that might be one way that we could think about why the implementation strategy failed. And so however you sort of depict this, I think potentially important to think about how and why your implementation strategies work. This slide is largely to suggest that our work is cut out for us. I mentioned that we know very little about implementation mechanisms. This is from an AHRQ funded R13, where we're developing a research agenda for studying implementation mechanisms. So we use this method called concept mapping, in this case, to identify challenges to studying mechanisms in implementation science. And there were 105 challenges or whatever in these buckets that are represented on this map. And so there are many challenges to this, but also opportunities. And I would just say stay tuned for an upcoming special collection in implementation science and implementation science communications, where we outline some of the steps forward in this research agenda. And we also have a number of investigators who are, including those some from Harvard, who are stepping forward and suggesting opportunities for advancing our understanding of mechanisms. This is the failed R01 that turned into a successful R01, where we're trying to build a database of strategy mechanism linkages and associated causal pathway diagrams for a number of implementation strategies. We're also developing psychometrically strong and pragmatic measures of mechanisms, because that's another obvious challenge in the field, is we don't have measures for many of these mechanisms that we might identify for implementation strategies. So at least trying to do a small part in addressing that, and Brian Weiner's leading that second aim to develop measures. And just in the last few minutes here, I just want to suggest that I think this won't be surprising to any of you, but sometimes as we look at the implementation literature, it's really often not clear, what people did, why they did it, how they got from point A to point B. And one of the challenges is really reporting in implementation science. So again, strategy terms are inconsistently used, definitions are inconsistently used, and the details of interventions and implementation strategies are often not there, which limits replication in science and practice, and ultimately precludes answers to questions about how and why these implementation strategies work. And so we've suggested, this is a paper led by Enola Proctor, where we suggested some guidelines or suggestions for reporting implementation strategies, hopefully carefully naming them, preferably using language that's consistent with an existing compilation or consistent with the prevailing literature, carefully defining it operationally for your study or setting, and then specifying things like, who are the actors involved, what are the specific actions that they're taking, what are the action targets that are being addressed through this implementation strategy. Is there anything about the timing or dose of the implementation strategy that are important? What are the implementation or other intermediate outcomes that you're addressing? And then I think really importantly, what is the theoretical basis? Is there any empirical basis? Or is it just sort of a pragmatic reason why you're using this strategy and why you're using these strategies in concert with one another? So oftentimes, as we talked about from the beginning of the presentation, even discrete implementation strategies within a multifaceted strategy could be specified using these guidelines. And I think there are a number of helpful examples where people have done this. in the literature, and it gives you at least some sense of how the strategies are supposed to work. And if you needed to replicate that strategy, you might be a little bit better off, at least. So of course, all does not go as planned, and as noted earlier, adaptations are often made on the fly, and so I think it's also important, and there's a growing recognition that we need to sort of track these implementation strategies over time, note the adaptations that are made. This figure on the left is from Amber Haley, who's at ViiV Healthcare, and she's noting here that we really need to describe our planned strategies, track use over time, and as we monitor barriers and potentially tweak our strategies, identify and describe those in detail. And so there are a number of folks that are working to do this more systematically. If you're familiar with Shannon Wiltsey-Sturman and Chris Miller and Anna Bauman's Frame IS, that's a nice framework for categorizing different modifications to implementation strategies. But there's a lot of work, and I think probably a lot of work to be done to make these processes more pragmatic for research and practice. So some of the references below here are efforts to do that. There's also, and we can talk about this perhaps down the road, but wanted to note this paper from Chris Akiba and colleagues who are really emphasizing this aspect of strategy of fidelity to implementation strategies. Just as we think about fidelity to our clinical interventions, it's important that we think about fidelity to implementation strategies. Are they being delivered as intended? And then lastly, I just wanted to point this out for those of you who are conducting implementation trials. This is a paper led by Luke Wolfenden that provides some nice guidance on designing, conducting, and reporting and implementation trials. So we just urge you to take a look if you haven't seen this one. I think it's a helpful paper and also potentially a helpful sort of primer on implementation science more broadly. Hopefully we have plenty of time for discussion. I see some questions in the chat, but thanks so much for your time and attention. And sorry if that was too fast and too much, which is often the challenge in these sessions.
That was outstanding, Byron. Thanks so much. Really terrific overview and lots of topics that we've had a chance to talk about some here, but not in such a clear and concise way. So we do have actually a number of people that have already posted questions and actually voted on questions that Beck will be sharing the screen. So you can see them here, and I think we'll probably just take them in order of priority here. So you can see first one here is, do we have an understanding of why the body of evidence is and work on how and why certain implementation strategies work is so small? Why they do and do not work? Why is the evidence so small?
I think I have two responses to that quickly. One is just probably the maturation stage of the field. So, I mean, if you think about it, like, we weren't even thinking very systematically about implementation and studying it very systematically years ago. And as that evolves, I think, initially the questions are just, whether or not things work. And I think the second part of the answer is both why we need to focus on this and why we know so little, is that I think the complexity and the myriad of settings and interventions that are being implemented, I think makes it really challenging to study mechanisms. I also think, I was going to say the overemphasis on quantitative methods. I mean, I think we're very limited with respect to, powering trials and things like that. If we think about only studying mechanisms through sort of a mediation analysis framework, I think we're really limited. And so I think one of the things that we're interested in is how do we use qualitative and mixed methods? How do we use other approaches to getting at mechanisms? So I think those are the thoughts that immediately come to mind.
Yeah, that's a great response. I think actually I share your perspective that after seeing many frameworks and theoretical constructs introduce, the fact that evidence is now that empirical studies are being done to test these actually is very refreshing. So I think it actually is the field advancing, as you've mentioned. So I think also, Becca, do you want to say you can actually voice your own question here if you'd like?
Sure. So one of the things we are really trying to do is make sure, maybe first time or second time implementation science grant writers really feel prepared. And I think as implementation strategies get more complex and it's not a single strategy people are thinking about, trying to think about as you're writing your first grant or your second grant, how do you show your stuff without trying to do too much in a grant with implementation strategies in particular.
Yeah, maybe two thoughts, and sorry if they're tangential, but the first thought is like you bring up a great thing that I didn't talk about in the presentation, which is that one of the worries is that our strategies are becoming way too complex and that we're recreating the problems that we're trying to address in implementation science, because we basically have strategies that are unimplementable or not feasible. And so I think it's great to see an emphasis on user-centered design, human factors engineering, and in terms of designing strategies that are user-friendly and are just well designed and thoughtfully designed. So that I think that's important to note as an aside. And then in terms of I think you raise another challenge with implementation sciences, which there are a number of challenges at multiple levels, and you can't solve every problem all at once. And so I think just like when we think about broad implementation frameworks like CIFR or others, you can always sort of draw a box around the specific area that you're focusing on, and sometimes a more targeted focused approach is actually probably more sellable from a grantspersonship perspective. And so that would be one piece of advice. And the last thing I'll say is just as I mentioned before, I think sometimes you can point to formative work or other work that you'll do to develop an implementation strategy. So I wouldn't necessarily think that you have to have all of the kinks ironed out prior to the grant proposal. If you can show how you're going to, for instance, engage stakeholders in the development of the implementation strategy, if you can, invoke a systematic process for doing that, I think that can be effective as well.
Great, terrific. And Clara, do you want to voice your question? Go on.
Thanks. Hi, everyone. I'm new. I'm actually joining you guys in March. So thank you for the invitation. But one of my questions, and thank you, Brian, I also took the D&I course at Colorado, and so I heard a version of this talk, and I really enjoy your talk. But one of the questions I had is, how do you separate out if something fails, if that failure is due to the implementation strategy or strategies, or if there was something inherently wrong with the innovation itself that you were trying to implement?
Yeah, I mean, I welcome others' thoughts on this. I mean, first, hopefully, oftentimes when we're doing implementation studies, we already have a solid sense of the evidence, and sort of that's, contingent that we're at this phase. I'm sure this group has talked a lot about, hybrid studies and sort of pushing implementation work earlier in the translational pipeline. But I think, I think that's a tough question. I mean, hopefully we have pieces in place to know if the implementation strategy is working as it's proposed, and so it might not be effective. But I think having a program theory for the implementation strategy and specifying mechanisms and hopefully measuring that or assessing that qualitatively is one way to think about, is the strategy even working as it's supposed to? If you find that the implementation, the intervention is obviously being implemented well, but just fails, that's potentially a signal that the evidence is either not as strong as we thought it would be, or maybe less relevant to a certain population or context.
Great. So one of the questions that comes up a lot for those of us who are engaged in community engaged or participatory models of implementation science is, where do the partner preferences come into strategy selection? And I'd say even furthermore, what if there's not full alignment around what are the preferences in terms of strategies between those of us who are thinking about the questions and have been doing pilot studies and engage in the science, and then working with partners who may, for pragmatic reasons or other sorts of reasons, really have a different perspective around the strategy they'd like to see tested and used?
It's a great question, and I hope you'll answer it, Dr. Bartels. But to share a couple of thoughts, I mean, first, like in some of the work around tailoring and strategy development, we're actually asking these questions about like where and how do stakeholders want to be involved, and so I think in some cases they're questions about like, you know, how much do stakeholders care about the evidence for implementation strategies and theories and things like this, and how in the weeds do they want to get? I'm you know, certainly a proponent of involving partners in this early and often, and it seems like if we're trying to do things as researchers that are, you know, not aligned with what their preferences are, I don't think that's a recipe for success. But I think, you know, what we've been trying to do is trying to think through how can we be most judicious with people's time and most considerate with people's time, and, you know, what parts, for instance, in a process like intervention mapping, what parts do stakeholders need to directly inform, and what can sort of, you know, researchers or other folks do and then bring into the process for feedback. And so I don't have a great answer for that, just to suggest that I do think it's a tricky balance. But yeah, I'd love to hear others' thoughts. I don't know who asked that question, but would love to hear others.
Yeah, I'll follow up with actually another question, which is totally related. Where does simulation modeling come into this, which we're increasingly being interested in as a means to prevent doing, you know, pilots that don't work, or introducing things that don't really have as much potential traction? Any thoughts about that as a technology that we'll increasingly be seeing in implementation science?
Yeah, I mean, I don't have a ton of expertise in this area, but I've seen colleagues. So for instance, Lindsay Zimmerman, who's at Stanford and the VA in Palo Alto, is using, you know, SD simulation approaches and the like to model implementation scenarios, and I think that it's a brilliant approach, and I don't have a sense of this group and the range of approaches you're using, but even like in a much lower tech example, I'm working with a group that's implementing a new model of emergency departments. So they're totally different service model in their system, and they're using something called oilcloth sessions, which is essentially like, you know, the blueprint of the hospital and Lego figures and which specialties are where and what are the workflows, and mapping through things like that. I think not the type of simulation that you're talking about, but I think that these types of things are going to give insights in the types of challenges that we might face, and the leverage points for addressing them. And certainly in that example, I think it's highlighted a number of those challenges, and so yeah, I'd love to hear more about what you're doing, but I think there's definitely tremendous potential for those types of methods.
Great. So I guess we're close to the end of the hour. I don't know whether Karen or Nitish, as kind of co-directors of this seminar series, any thoughts or comments or questions you'd like to add in the last couple of minutes?
Just to thank Byron. This was terrific, and I think one of the things that I always take away, and one of the reasons I like to hear him talk every chance I can, is that this is moving really fast. There's a lot of development in this space, and as you can see by all the references and the things that are, you know, about to come out, and I really appreciate all the the literature side, and it really helps people, I think, keep up when speakers do that. But it's really just telling you this is a real space and to be watching, to be working in. So that's just super helpful. Really terrific. Thank you, Byron.
Yeah, Byron, let me add in that what a tour de force. Thank you. It was a real treat to not only sort of have that all put together in one place, but watch your name fly through the screens, and a real sort of a testament to scholarship and implementation research. You know, just as a plug, as somebody who's more clinically and epidemiologically inclined, you know, the understanding mechanisms, you can kind of sort of think of it as, you know, I don't really care why aspirin works. I just want to know that aspirin works. Does it actually save lives? But I think, you know, your work, others in this field, and even our own evolution is teaching us that mechanisms are really massively important. And that, you know, this idea of figuring out new ways to do this more efficiently, because we cannot, as you say, power trials for mechanisms when we can barely power them for outcomes, is really where the field needs to go. And thank you for sort of pushing us in that direction.
Great. Well, thank you so much, Byron. And in the last second, I'm going to turn it over to Becca just to give us future attractions. But Byron, just fabulous talk. So much. We're really grateful for you joining this group and really giving us all the insights that you provided in a terrific, very short period of time in a very fast-paced area. So thanks so much.
Pleasure's mine. Thank you so much for the opportunity, and good to see you all.